Hi, everyone. Welcome to another episode of The Heart of the Matter. My name is Bourann. I have Anisha here in the flesh with me today, and then Ankit over there on the other side of the camera. Today, we're going to discuss a really interesting trial. This is sort of like a different kind of concept than some of the things that we've discussed. And this is about the concept of ischemic preconditioning. And the study that we're going to discuss is called the PRINCE trial, which is on the effect of remote ischemic preconditioning on myocardial injury in non-cardiac surgery. And so I'll kind of give a brief introduction to the concept of remote ischemic preconditioning and how this is relevant. But this topic touches on this idea where we see a lot of post-surgical myocardial injury, MI, or other like similar types of complications like stroke, acute kidney injury, things like that that occur frequently. And so we have looked for ways to try to mitigate that injury. And so this concept was first introduced back in the 80s when a researcher basically in animal studies had clamped, I think they were using dogs as their subjects, clamped the dog's LAD. And then what they saw is in subsequent ischemic insults that the area where they temporarily clamped that LAD, so that LAD territory, had a significant reduction in infarct size. And the idea behind it was that we were giving some type of like a temporary ischemia to the region, which helped signal some protective mechanisms to prevent more widespread infarct down the line if there was repeated ischemic injury. And so that was the idea of where this concept came from. And then this was tested on more animals with similar results. Ultimately, they started testing this on human subjects. And back in the early 2000s, some researchers were able to show that there's actually a way to induce this improvement in perfusion and protection against ischemic injury from like a remote location. So it doesn't have to be the exact location where you're inducing that ischemic insult. It can be something distal. And what they did is they used a blood pressure cuff in the arm or leg and inflated it to 200 millimeters of mercury or just like high levels in general. And what they noticed is that those patients they did this prior to surgery, and then post-surgical patients, the ones who had this pre-ischemic conditioning, were found to have lower rates of MI, lower rates of stroke, acute kidney injury, lower troponin levels perioperatively, which they think is, associated with worse outcomes, even in the absence of like an official diagnosis of MI. And so this concept comes up as a mechanism to protect our patients from post-surgical MI, which is a complication that happens not infrequently in cardiac surgery and in non-cardiac surgery. And so there have been studies in the past, albeit not randomized and not blinded and not necessarily placebo-controlled or large studies. There have been small preclinical studies. There have been smaller scale studies to suggest that there actually is a benefit in doing this remote ischemic preconditioning on patients who are going for surgery. And so the PRINCE trial, the point of it is to test this on a larger scale in a randomized fashion, in a blinded fashion, and particularly in this case, we're looking at non-cardiac surgery. One of the caveats, which we'll talk about later, but just to bring this up now, is that the patients in this study, any of them who underwent surgery, they did not receive propofol. And the reasoning behind that is due to the mechanism of this remote ischemic preconditioning. And the idea is that when you induce some temporary ischemia, you are signaling these pathways that promote anti-apoptotic mechanisms of mitochondrial survival. And it's like a way for the body to learn how to protect itself against further ischemic injury. And so it signals a lot of these cascades to do so. Now, propofol, which is a common anesthetic used in surgery, has mechanisms that directly counteract this And so what it ends up doing is it blunts any of the impact that these researchers expect to see from the ischemic preconditioning. It has like multiple mechanisms through which it does this. It affects mitochondrial consumption. It also has like some pretty strong reactive oxygen species scavenging, which is one of the ways by which this ischemic preconditioning is thought to help train our tissue to better respond to ischemic insults. So, in the past, in some of these studies, they've seen that the use of propofol has mitigated that response. And so, in an attempt to remove that as a confounding factor, all the patients in this study did not receive propofol in anesthetic during their surgery. So it's kind of a long-winded introduction, but it is sort of like a uncommon concept. I don't necessarily think a lot of people have heard of it in just the general medicine sphere. So that's what this study is aiming to investigate.
I mean, I know I haven't heard of it
Yeah,
before today and before we learned about it to present to you guys.
same.
So I'm going to talk a little bit about the methods. So basically, it was an international parallel group, pragmatic, double-blind, randomized control trial with a one-to-one allocation ratio involving 25 hospitals in 8 different countries. So the patients that were enrolled, only if they met all of these specific inclusion criteria. So their age had to be over 50 years old. They're intermediate or high risk for non-cardiac surgical procedures under general anesthesia, and they had preoperative antiplatelet therapy as a proxy for cardiovascular risk. So the surgical risk stratification that they used was defined according to ACC and AHA guidelines. And then the exclusion criteria that they used was if you were pregnant, if you had an acute MI in the last month, unstable or ongoing angina, and peripheral vascular disease affecting the upper or lower limbs. Um, so basically, the way that they did this is before general anesthesia induction, an unblinded research staff member placed a blood pressure cuff on the upper or lower limb of the patient. In the treatment group, the procedure was started immediately after the induction of general anesthesia. And according to the most widely adopted method, the procedure consisted of 3 cycles of ischemia, each lasting about 5 minutes. And they did this, like Bourann had mentioned, inflating the blood pressure cuff to about 200 milligrams of mercury, followed by a 5-minute reperfusion with the cuff deflated. So now in the sham RIPC group, the release valve was left open to stimulate the RIPC procedure and maintain the blinding, while the cuff inflation was mimicked for the same intervals and duration as the intervention group. So there was one person, the staff member, who knew whether it was, if the release valve was left open or not. And so basically, as Bron also mentioned, they previous evidence had suggested that propofol could interfere with this with the RIPC induced organ protection. And so all of the patients were managed without the administration of propofol for anesthesia induction and maintenance. And then the attending anesthesiologist defined all other elements of the anesthetic management according to the clinical needs and standard practices. So the primary outcome that they were looking for in this study was a rate of postoperative myocardial injury defined by an increase of the serum cardiac troponin levels above the 99th percentile of the reference limit. And a single value of the serum cardiac troponin above the 99th percentile was considered sufficient to define the presence of myocardial injury. So then their pre-specified secondary outcomes. So these secondary outcomes included myocardial infarction within 30 days of randomization, stroke within 30 days, acute kidney injury, 31 within 7 days. Oh, sorry, within 7 days. And then, or a need for the ICU, length of hospital stay, and an all-cause mortality at 30 days. So it's interesting. All of this is very new. All of this is they have different primary and secondary outcomes. I mean, I think expected ones, but I think the way that this is all conducted is very interesting. Ankit, would you like to talk to us a little bit about the results and some of the baseline demographics of the study?
Yeah, so to start off, we'll talk about some of the demographics. So there are about 40% women in both groups, 90% a white population, predominantly done in Europe. And then greater than 80% of patients had RIPC done on their upper limb, where the cuff was placed. To talk about at least the summary of patients, so most of our patients in the study were smokers or had some sort of smoking history. They were intermediate to high risk, as we have mentioned before, with the ASA score above 3, and then suffered from hypertension being one of the most common comorbidities. And then the most common types of surgeries were abdominal or intrathoracic surgeries, about 34%, and then 44% of patients were high or underwent high risk surgeries. So now to go over some of the results. So the primary outcome, there was no difference in myocardial injury in 215 out of 566 patients in the RIPC group versus 223 out of 596 patients in the sham RIPC group. So that's about 38 versus 37.4%, and the relative risk is 1.02, and p-value is 0.84, so pretty high. So no significant difference. So for some of these secondary outcomes that Anisha mentioned already, there was no difference in any of those clinical endpoints, MI, stroke, AKI, length of stay, ICU admission, and then all-cause mortality. And then to go through some of these safety analysis and stuff like that. So there's only two outcomes that were significant. One being the skin petechiae in the experimental limb in the RIPC group, which is as expected since that's the one that you're causing ischemia to, with a p-value of 0.01, and then unplanned hospital admission, which was higher than RIPC group as well with a p-value of 0.04. Notably, there was an unexpected increase in the number of patients with elevated troponin release in the subgroups of patients receiving RIPC with cuff placement done in the lower limbs, which was interesting. So to sum this up, finally, there's no beneficial effects of RIPC compared to sham RIPC on the rate of myocardial injury as a primary outcome and other complications among adult patients that are undergoing intermediate to high risk non-cardiac surgery. So with all of this in mind, so now we're gonna talk about the discussion. What did you guys think was important and what did you guys gather from the study?
You want to go?
Sure. I mean, I thought what's interesting is that, them using this broader, obviously all the studies that have been done have been mixed in the past, and they've been smaller sample sizes. And with this larger sample size and taking the propofol out of it, the fact that there was literally no difference in either of the groups, and if anything, actually, I think that they did a multivariable analysis that it had, and they said that there was no role in reducing the rate. And actually, there was some elevated postoperative troponin levels that were associated with an increased incidence of postoperative complications. So I feel like that actually, that it just shows that once you increase the sample size, that things really change, and also making sure to take out any confounders, that things really change. I mean, it sounds like we all discussed, it's new, it's interesting, it's a unique idea, but clearly there, I'm not sure if it warrants too much more further investigation. But that's just my opinion. It was an interesting thing to do and learn from.
It
But
is interesting. I mean, this is the first time that we've had like a very high quality study to investigate it. I think that there is probably some validity to like the concept behind it. But whether that translates into like appreciable clinical outcomes, in this case, it did not. So maybe there is a way to utilize this type of re-ischemic preconditioning in another manner, but in the way that it's affected here, it seems like it's not super beneficial. And I mean, I'm sure that there will be more studies about this. I think that, you know, um, basing it all on one study, albeit this is like higher quality than previous studies and larger sample size that will have more information in the future. But mechanistically, it makes sense. And the idea is there for sure. It just seems that there is possibly maybe harms that we're not aware of in doing this ischemic preconditioning that maybe is preventing there from being like a significant benefit in our patients. And I'm sure as they research it more, maybe they'll be able to come up with some reasoning as to why some of these patients had even like worse outcomes. Although the primary endpoints and things like that didn't necessarily show that they were worse off for it. But some of these secondary things, they had worse outcomes in. So I guess we'll see. But, in this case, it seems like we don't have super promising information.
yeah.
What do you think, Ankit?
Yeah, I'm on board with you guys. I think it's an interesting study. I think the concept's really cool. I just don't know how applicable it is. Again, I think this was evaluated in non-cardiac patients, and I think the one done in cardiac patients was a little different.
Hmm.
It's so hard to interpret all these studies without being it super standardized. There's a million things you can use for anesthesia induction and a million different ways you can do this. So
This is true.
at least this study, at least it didn't have a significant
Hmm.
difference. One thing I want to mention, at least for the study that we were looking at. So some limitations. There was no preoperative troponin done. Obviously, some patients do have some baseline troponin elevation, but if that was randomized, generally that is removed. But again, that wasn't done in the study, so can't really account for that. The other thing is the primary outcome is a myocardial injury, as we mentioned, like it's like a laboratory definition.
Mhm.
That kind of interferes with its clinical translation into, MI. But again, MI was included as a secondary endpoint, which is reasonable. And then one thing that's interesting to me, I think they did this again, as Anisha mentioned, after anesthesia induction. So I don't know if doing it like 24 hours preoperatively or even like the number of times you do ischemic preconditioning, I don't know how that would change outcomes, but I think those are some interesting things to look forward to if that is in the pipeline.
I
Uh,
also wonder the thought that came up is I know that you were mentioning and we had talked about this is all non-cardiac and Bourann had mentioned that in the dog study that it was with the LAD, right? So it was in
yeah.
a cardiac um consideration and I don't know how
Yeah.
ethical it would be to do
Yeah,
it.
exactly.
Yeah,
Clinically.
obviously in cardiac
Yeah.
patients for us with humans, but I wonder if, in some theoretical world that there would be actually maybe more benefit of having those markers be more present in our actual like cardiac perfusion and
Hmm.
that would be a different
Which
thing.
are inherently higher risk surgeries and surgeries that you would want your patients to be optimized in. So, I
Yeah,
mean,
right.
maybe we'll find that its use is limited to cardiac surgery.
Mhm.
In this case, this was non-cardiac, and maybe there isn't a benefit. I think some of the ideas of where they got that this might be beneficial is that they did, in the earlier times when they were just testing out this concept, they did it not just on, like coronary tissue. They did it on like hepatic tissue, kidney tissue, and saw similar effect at a local level, which I think is sort of the idea behind seeing also if it improves AKI and if it's benefit in non-cardiac surgery. But again, like we are saying, local effect doesn't equal significant clinical outcome. So we'll see.
Very cool.
Well, um, today I was gonna say, what's our question for the day? So, do you want to come up with a question for today? You have anything off the
Oh,
top of your head?
okay. Yeah, I guess I mean, I don't even have an answer to this, but you guys will go first. All right. What is your guys's dream vacation destination that you haven't already been to? A place that you've yet to go to that's like on the top of your bucket list.
Okay.
Who's going first?
You want me to go first? Okay.
Yeah, go ahead.
I have been fortunate enough to travel to many countries in the world and seen a lot of things. I think based on all the things that are going on, which all three of us are applying to fellowship, things have been busy. We haven't really, we're just now starting to see the sun, the heat wave is really going, I think, in most of the United States right now. But somehow the place that's coming to mind is the Maldives, just like I just want like an oasis, just like sun and just relaxation and just a little bit of ease and just as far away from everything as possible.
Yeah,
But it'll come when the time comes. So,
that's a good choice.
yeah.
I like that. Ankit?
I like places that have like good nature, have beaches and mountains. So, I mean, the first thing that comes to my head in the US is Hawaii. So
Mm,
that's one. And then I also wanted to go, there's like places in like near Europe, like the Azores,
Ooh, yeah.
which I heard was really cool too. So probably one of those places.
that sounds
Nice.
awesome. What about you, girl?
Um, you know, I don't I don't have an answer for this question. I didn't get time to think about it. But I think okay, what immediately comes to mind, um, and maybe this is because I just saw like some influencer or something go on a trip here, but there's I guess like a town in Turkey or a city called Bodrum and it's
Mm,
like very tropical.
yes.
And I think I'm on the same wavelength as you as wanting like a very relaxing, tropical, peaceful earth, wind, air, sun, whatever like vibe. So I think maybe that's what I would say.
Yeah.
I guess I mean I've never been there. I've been to Turkey, but
Yeah, not to
so
boat
so
trip.
that counts.
Neither have I.
Yeah,
Yeah.
that's my answer.
For some
Well,
reason, I just knew that you were gonna pick a travel related question. I don't know why.
Why?
I
we're
don't
all
know.
gonna get out of
Oh, I
here.
think yeah, that's fair.
Yeah,
Aren't we all?
Yeah,
It's
yeah,
been a long time since we've had vacations, I
that's true.
think.
Yeah, it's
Right.
yeah, for sure.
been a while. Well, thank you everybody for joining us for another episode of The Heart of the Matter. We will see you all soon. Bye.
Bye.
Thanks.